Hi, I'm Mikkael Sekeres, Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center at the University of Miami. And I'll be discussing the PANTHER trial, which was a randomized study of pevonedistat and azacitidine versus azacitidine alone in patients with higher risk myelodysplastic syndromes, chronic myelomonocytic leukemia, or oligoblastic acute myeloid leukemia. In this trial, we randomized 454 patients to receive the pevonedistat monotherapy versus pevonedistat combined with azacitidine. Pevonedistat is a NED8 activating enzyme inhibitor. Our primary endpoint for the trial was event-free survival, with a secondary endpoint being overall survival. In general, patients were well balanced between the arms with a median age of 73 to 74 years, approximately equal distribution among different IPSS-R categories. A total of 27 patients had CMML and a total of 103 had oligoblastic AML, with the remaining patients having higher risk MDS. Patients were also well balanced with respect to molecular abnormalities, the most common of which in our sample were ASXL1, RUNX1, SRSF2, STAG2, TET2, and TP53. The overall response rate in the intention to treat population was approximately equivalent between arms at 28 to 31%. Interestingly, within the higher risk MDS arm, the CR rate was 32% in the control group in patients receiving azacitidine monotherapy, which is about 14% higher, as has been seen in a number of previous trials involving azacitidine monotherapy. In the intention to treat population, event-free survival and overall survival were statistically similar between arms, although the advantage was for pevonedistat and azacitidine. Interestingly, in the higher risk MDS cohort, the median event-free survival for patients receiving the combination of pevonedistat and azacitidine was 19.2 months versus 15.6 months for those receiving azacitidine. The median overall survival was 21.6 months for those receiving pevonedistat and azacitidine versus 17.5 months for those receiving azacitidine, a difference of approximately 4 months, and there was a trend toward significance with that difference. Overall survival in patients who had AML and CMML were similar between arms. Patients remained on therapy for a median of 8 to 9 cycles, and adverse events were similar between groups. In a post-hoc analysis, patients who received more than 3 cycles of therapy had an overall survival that was significantly greater in the pevonedistat and azacitidine arm at 23.8 months versus 20.6 months in those receiving azacitidine monotherapy. So our conclusions from this is that the study did not meet its primary endpoint of event-free survival. However, there were clear signals of an advantage to combination therapy with respect to median overall survival. And that 4-month difference was exactly the same as what we saw in the phase 2 randomized study of azacitidine versus azacitidine and pevonedistat, and also what we saw in the North American intergroup trial of combination therapies versus azacitidine monotherapy. Our take-home points from this trial are 2. The first, given the high CR rates we saw with azacitidine monotherapy, which we attribute to strict language in the protocol to keep patients on therapy without dose reductions and on schedule, we need to continue to emphasize the importance of remaining on azacitidine-based therapies for at least 4 to 6 cycles. And secondly, that in the future, randomized trials of combinations versus azacitidine monotherapy must be powered to show a median overall survival difference of 3 to 4 months in these populations, instead of being powered on the 6, 8, or 10-month differences they currently are. Thank you so much.